Thanks very much. Great talk by Eric. Agree with all of that. So those are my conflicts of interest. I'm going to talk to you about the RADIANCE program, which is the clinical trial program that led to the approval of the ultrasound-based renal denervation. I was involved in research programs for both RF and ultrasound. So hypertension is the most important disease in medicine. So a lot of people find that statement somewhat provocative or surprising, but it's fairly uncontestable. It causes more lost years of life in the world than any other disease. It causes more death than any other disease. It causes half of all heart attacks and strokes and is the upstream cause of heart failure in more than 50% of cases. It is a major cause of renal failure, and it is a major cost burden to the global economy. And it is affecting around 1.4 billion people, so about 1 in 3 of adults will have hypertension. And reducing blood pressure is an enormously powerful intervention, and this is something, even as cardiologists, a lot of us don't quite get. If we reduce blood pressure by 10 points, we would expect to get a reduction in MACE of around 20%, stroke of 27%, heart failure 28%, ischemic heart disease 17%, and cardiovascular death of 13%, just by reducing blood pressure from 150 to 140, never mind going lower. So given the enormous potency of blood pressure reduction, which is unparalleled in almost any other area of medicine for reducing hard events, how are we doing? Well, we managed to diagnose half of the patients in the world who have high blood pressure with hypertension, so that's not such a good start. We don't bother treating about 30–40% of them, which is a dismal follow-up. And then when we do treat them, we're controlling a minority of patients, which again is disappointing. So of all the patients out there, only 14% are controlled. This is not to pick on the US, but I just thought it's relevant given that I'm here, because we're just as bad in the UK. How well is the US doing at controlling blood pressure? So this is pre-pandemic data. It runs into 2017, 2018. And in fact, there's just been an update a week ago that shows that it's pretty similar. So about half of patients are not controlled to the weak standard of 140. We're now aiming for 130 in the significant majority of patients with hypertension. So we can't control half of patients to a poor standard. And the data from last week for, I think, 2021, 2022 for the US showed that we're only controlling about 28% of Americans to the standard of 130. Now, we've had more than enough drugs for decades. So people who say drugs are the answer to hypertension, I would say I support the statement in principle, but the medical profession and the patient population do not support the statement in practice, because we've had more than enough drugs for decades to control high blood pressure. But patients aren't taking them and doctors aren't prescribing them, and we have to start listening to that and start thinking about why. So this is where device therapy comes in. It's not a cure for hypertension, but it is a treatment, and it is a good treatment. So how does the ultrasound work? It's designed to deliver ultrasound energy into beyond the wall of the renal artery, into the fat that surrounds the renal artery where the renal sympathetic nerves sit. So we're trying to ablate, destroy the renal sympathetic nerves. It's about 1/3 of the total body fight or flight system. So we're not abolishing the ability to get your heart rate up or your blood pressure up when you're running away from a tiger. We are just modulating what is an overactive sympathetic nervous system. So we put a balloon through a 7 French guide into the renal artery, and we do 3 sonications lasting 7 seconds each, heating up the periadventitial fat to around 70 to 80 degrees at that point. And then we cool the near field, the wall, by running water through a closed system in the balloon. So the balloon is kept cool with a water system inside of it, but the heat goes out through the ultrasound deep penetration to about 6 millimeters. So if we were made of thermochromic gel, this is what would be happening in an ultrasound renal denervation. So the first one you've already seen there, and you see how the cooling fluid that runs through the balloon protects the near field. So that's why we don't get stenoses. We haven't seen them to any significant degree in the clinical trials. But the energy will go out beyond that cooling effect and heat up enough the periadventitial fat where the renal sympathetic nerve sits and destroys them permanently. So that's all well in theory. So does it work? So we've published 3 Chubb-controlled RCTs just with this device alone. I'm not sure there's any other device in cardiovascular medicine that can compete with just this. This is incredibly powerful data. Sham control studies are very hard to do. I've done 10 of them now, and they're not easy. How did we do it? We had SOLO and RADIANCE 2. They're both a similar design. RADIANCE 2 is the pivotal trial. SOLO was the first trial. And we did them off medication. So why did we do that? Because that's how you prove a new drug. If I bring up a new drug, call it dalapapil, and I want to get it tested and introduced to the market, the FDA will ask me to find patients with mild to moderate hypertension, take them off all their drugs, so there's not oscillation in adherence and therefore oscillation in background blood pressure. You'll then randomize them against a placebo if it's a pill, and then 12 weeks later, you'll demonstrate that it's reduced blood pressure with a safe print, and that's how you get a drug started into the market. That's how we did these trials. We did a 2-month primary endpoint for daytime ambulatory blood pressure in patients off meds, and we showed that at 2 months, there was a greater drop in blood pressure with denervation versus a sham procedure. And the sham was a full renal angiogram with a script where we pretended to be performing the procedure, and the patient was under sedation, and so had little memory of the procedure. TRIO is perhaps the more clinically pertinent one. What we did was we took patients who were on 3 or more drugs, who were uncontrolled, and then we gave them a triple pill. So it varied according to where you were in the world, but in the UK, it was olmesartan, amlodipine, and hydrochlorothiazide in a single pill, and we watched them take it at each visit, so we standardized blood pressure. And that's a key thing. Doing an on-med study is incredibly difficult, because if you've got a patient with 3, 4, 5 pills, they may not have taken all of those pills or any of them on a random visit. So they may have taken 4 pills on the first visit and 1 on the second visit and 3 on the third visit. What we did was we gave them a single triple pill and we watched them take it on the morning of each visit, and then we subsequently did the ambulatory blood pressure monitor. So we standardized blood pressure, and that's how this trial was successful. And this is the headline message. So this is ambulatory pressure. So remember, if you have a 10-point drop in office pressure, you'd expect about a 5-point drop in ambulatory. So here we're seeing in the treatment arm an 8-point drop in SOLO, an 8-point drop in RADIANCE, and an 8-point drop in TRIO. They're so similar, they look like they're fake, but I can promise you they're real. The sham effect, there shouldn't really be a sham effect in a renal denervation trial. Most of the gray bar drops in the sham control are due to reintroduction of medicines, and we demonstrated that with urine chromatography, so we knew who had medicines in them. If you look at what the true sham effect is, it's less than 1 millimeter of mercury, and that's relevant to interpreting trials in the past. Trials with big sham effects was likely variability in the amount of drugs that were in the system. It wasn't a placebo effect. Who were these patients? They were mid-50s, and that's not an accident. They're probably the best patients for renal denervation because they're old enough that they've had a good go at lifestyle and medicines, but they're young enough that they're going to get decades of blood pressure lowering effect and therefore probably the most bang for the buck. In the trial, they were majority male, and there was some representation of minorities, but not overwhelmingly so. They're mostly overweight at a BMI of 30, and the GFRs were preserved in these trials, with a small proportion having diabetes. This is a putting together, this is a patient-level meta-analysis of all the trials, and so it says 1.7 meds when they went into the trial, but of course some were off meds and some were on a triple pill. How severe was the hypertension? It was only mild to moderate, and this is relevant to the effect size. So the only thing we've ever proven dictates the result of renal denervation is the starting blood pressure. The higher the starting blood pressure, the bigger the fall following renal denervation. We've proved that in over 40 studies now. It's not just regression to the mean. I've got a paper coming on this. But we've also seen this in drug trials, that the higher the starting blood pressure, the bigger the response. How severe was it? Office pressure of 155 and an ambulatory pressure of 150. We had to take relatively mild hypertension because to take patients off their meds and leave them uncontrolled for several months, we could only get ethics to do that if we took mild to moderate. We couldn't allow people to have blood pressures of 180, 200 if we were going to leave them off meds for a few months in the sham control arms. It's very consistent across different measures. So on the left, we have daytime ambulatory, nighttime response, 24-hour ambulatory, home systolic, and office systolic. So it appears to be reducing blood pressure. And although you have these sham subtracted values on the bottom that are less impressive, what you get is the blue bar, because the sham effect is not a sham effect. It is drug reintroduction. So the blue bar is what you're going to get in your patients if you treat people at this blood pressure. And same response with diastolic. Always on, this is relevant. So some drugs are short-acting, some drugs are not taken. With RDN, once you have the procedure, and if you respond, as about 2/3 to 3/4 do, then you get a 24-hour effect that will last for years. We've got data out to 10 years with RF in over 200 patients. We've got data in thousands for RF out to 5 years. And some preclinical work I did with radiofrequency denervation suggests that these nerves are not going to come back. So it looks like it's going to be a permanent effect, but our minds remained open given that we've only got to 10-year follow-up. This was an interesting analysis that we did in JAMA Cardiology, led by RJ and myself. The starting blood pressure determines the response. So if a patient comes to you and says, am I going to get to control after a denervation? Well, you've got a fair chance of doing so, about a 50-50 chance if you've got mild hypertension, if your ambulatory begins at 135 to 145. If you've got more severe hypertension, you've only got a 1 in 10 chance of getting to control, so this isn't a cure. However, the higher the starting blood pressure, the bigger the fall. You're getting 10 points on ambulatory. So that's about 2 drugs worth of effect, 10 points of ambulatory blood pressure reduction. So the higher the starting blood pressure, the bigger the fall. That's who you want in your programs. And if you look at a number needed to treat, if you're looking for, say, a 10-point drop on ambulatory or getting the patient to control, half of them will get there. So you're going to need to treat for a sham subtracted 3 patients to achieve that target. But in reality, it's 2, because what you get is the blue bar. Very safe. There was 1 non-cardiovascular mortality and 1 repair in over 500 groin procedures. So remember, this is heparinized. So it looks like we're getting better at groin access. Contextualizing reductions. This is the UK experience. It's the largest investigator-led registry to date that I published about 8 years ago. And if you look, mild to moderate hypertension, which is the red bar, gets about a 6-point reduction on ambulatory. But if you look at the more severe blood pressures, so this is severe and then very severe in green and purple, you get a much bigger response. And that's important for selecting your patients. Go for the more severe patients and you'll get bigger responses. And it looks like it's durable at 36 months and at 12 months on stable meds. We're seeing a consistent effect. And so it looks like there's no evidence of attenuation. So in conclusion, the management of hypertension is clearly suboptimal around the world. More drugs will not change this because patients have to take the drugs in order for the drugs to be effective, and doctors have to prescribe them. And we've had over 50 years now of enough meds and enough patients telling us that they don't want more meds. Yes, maybe the small interfering RNA inhibitors will help, but renal denervation is now a proven and approved therapy that can offer a different approach of constant background blood pressure reduction. We're now at 30% control rates for our new office blood pressure target, and we now have a safe, effective procedure, albeit with a 1 in 4 non-response rate that has about 1 drug worth of effect if you treat patients with mild to moderate hypertension, but 1 to 3 drugs worth of effect if you treat more severe hypertension. And that's worth having. And as we've heard from Eric, it's a 45-minute day case procedure for most patients with ultrasound. It's under sedation. They all go home in that afternoon, and very few of them have expressed any concerns about the pain that they experienced during the procedure. They tolerate it. The target population, as you've heard, is resistant hypertension or those who are intolerant, and I strongly endorse Eric's recommendation for all sorts of reasons. Interventionists shouldn't be working these up. It's better to have a non-interventionist working them up for all sorts of reasons. You'll have to work your way through a number of patients to get to the right ones. It's better to have a specialist doing that, and you concentrate on delivering effective therapy in the cath lab. Thanks very much.